Hey, welcome back to the podcast. I'm your host, Ben Imes, here exploring the depths of healthcare. We've got a really exciting guest today. I would like him to introduce himself and we can kind of get going from there.
All right, sounds good. And thanks again, Ben, for having me. My name is Dr. Danny Seidman, primary care physician, sports medicine physician by training. I'm coming to you from Metro Detroit area.
Hey, there we go. Big win yesterday for the Lions. I don't know if you're a
Sure
Lions fan
was. Very exciting. Yes. Kids and I were going nuts. So it was fun to
because
watch.
that was a tough first week, I do have to say. I know that was not what was expected for this season, but a good rebound.
Absolutely. Yeah. And a lot of fun.
Yeah,
High scoring,
exactly.
high scoring affair.
We love that. We always love that. Well, tell us a little bit about yourself, Danny. For my listeners, if you take a look at Danny Seidman's LinkedIn page, you'll see about 100 different things. He wears 8 different hats, I think, all at the same time. He's a man of many talents. But sticking with our depths of healthcare kind of hemisphere universe right now, I just wanted to invite him and Danny, get your thoughts on kind of where medicine is going from what you've seen in your practice, whether that be primary care or concierge medicine, but what different things you're innovating in your practice at this point and what you kind of have seen out of training so far.
Sure. Yeah. So just to kind of set the stage for all of that, uh, you know, figured out pretty early in my 20s I wanted to be a physician, and I had a lot of physicians in the family. Seemed like they enjoyed their work, felt like they were doing something worthwhile for people. And so I went to medical school, a couple years in Florida. Took me up to Long Island. Right at the time, actually, they were filming that show Royal Pains from back in the day. We were
Yeah.
stationed at Southampton Hospital, so they'd often close to do some filming there, which
Uh,
was always entertaining. And then found my way back to Metro Detroit for training and
mhm.
raising a family. I did some primary care training and then did a fellowship in sports medicine,
There you
which I
go.
absolutely loved. Joined an academic practice. So joined the residence near downtown Detroit, and I thought I had my forever job. I was going to be teaching, spending one day a week on sports medicine, primary care. I just absolutely love being with the residents. Keeps you, fresh and up to date. Lots of good energy. And when I came on, this is a very common experience for those who don't know what it's like as a primary care doc coming out. You sign this contract, usually a 1 or 2 year guarantee, and after training, it looks massive, right? It's
Yeah.
all been making kind of the bare minimum for a couple years, bunch of debt. So you get really excited and signed on, and about 18 months in, sat down with our department chair, and he's like, Danny, great job. Things are going well. Just so you know, you've been taking 40 minutes for your physicals. We're going to need to bring that down to 20. And if you want to continue making your same salary, you need to see 5 to 6 more patients a day on average. And so this isn't like a metric you need to chase after to make a little extra or make a few bucks more. We're going to start decreasing your salary unless you do more with less. And yeah, and this is super common. This is kind of like the way things are in hospital based medicine.
Right.
And after that meeting, I started hunting immediately for a new role. And again, like great people, great department. I really enjoyed my time there, but I just knew it wasn't for me.
Yeah.
Not to be, cramming a bunch of people into short of time, appointment slots and
Totally.
trying to make all that work. And so I
Mhm.
found a local startup in direct primary care. And direct primary care, for those who aren't familiar, it's primary care without the insurance. We charge a very reasonable monthly fee for a monthly membership, and that gets you lengthy appointments with your doctor, 24/7 on call service, and other benefits, things like direct pay for labs, heavily discounted
Yeah.
labs and imaging.
Yeah.
And it's amazing. Direct primary care, you could compare it almost to like car insurance. Health insurance should be for the big stuff like surgeries and procedures. And the basic stuff you should pay cash for because it's relatively inexpensive compared to other things. It is predictable, use about the same amount of primary care most years, similar to a car, right? We don't use our car insurance to buy tires or gas or windshield wipers. And so that's how we've adopted this model of primary care. And this particular primary care office was situated at an employer, and the employer
Oh, okay.
paid for the membership on behalf of their employees.
Yeah, I've heard of that
But
before.
yeah, it's a great way to do it, in my opinion. Great benefit. And this was back in 2019. The model was just kind of getting started in the state of Michigan.
Yeah.
And then fast forward to the pandemic, this employer had about 1,500 people. They grew rapidly to about 10,000. So our little office
Mhm.
started to get overrun. But the demand for these services grew. And
Right.
over the next 6 or 7 years, the group just opened office number 8.
Wow.
And so they've been growing tremendously. And my job kind of, I have a public health degree as well. So early in COVID, I was part of
Mm,
the whole, what do employers do? How do we develop
right.
these strategies that are in alignment with what the CDC is asking for and keeping people safe, and but also
Right.
allowing life to continue. And so spent a lot of time on that. And then
Yeah.
yeah, and so we can get into kind of what that model looks like, innovations in that model for sure.
Yeah.
And then
Yeah.
yeah, just recently I left that what was called senior medical director role to start my own company for consulting on health plan design for employers.
Okay.
So
Okay.
that's the gist of it.
Wow. I mean, did that, I'm just going to touch on kind of the high level stuff at first, I think. Did that feel like a dream being shattered when you realized that hospital, primary care, medicine, the stuff you'd trained and really enjoyed, working around the residents and the teaching aspect? Did it feel a kind of dream crushing at that point and kind of where do I go from here in a sense?
Yeah, I think that's I've never used that phrase before, but it's a perfect phrase to describe how it felt. Always kind of saw myself as a company man. I was
Yeah.
hoping to find my spot and spend 20, 30, 40 years there, the whole, uh, build a legacy and have people who, you've been able to train and see them go out and succeed and hopefully work with them for many, many years. That's just not how, yeah, it hurt initially, but I think with time you get over it. And now I know this is business as usual for employed primary care at a hospital system. So it's nothing personal. This is
Right.
just the way the systems work. And there was a fresh, grad coming out to replace me. And I think they've probably been replaced two or three times with the next fresh grad.
Of
So it's
course.
how these things go.
It's how the medical community is being treated, sadly, as of the last, we'll call it, I don't know how far back I would go. I've only been in medicine for about, 5 years or so. So I would say it's definitely longer than that.
Yeah. I came out in 2016, 2017, halfway through. So it was around that time I experienced it.
Yeah. And so talk about that transition. I mean, I've heard of these membership models for primary care. Definitely I've heard of the big businesses who basically have their own clinic, but I've also heard of kind of community clinics. Is that what the direct primary care clinic that you were a part of, is that what they're transitioning into now?
Yeah, so we have kind of a hybrid model. So the group I worked
Okay.
for, we have some on-site locations, so it's only
Sure.
available to that employer.
Yep.
And then a lot of the other locations are community-based. So,
Okay.
an employer could say, "Oh, we're in this metro area. We don't have the funds, we're not large enough with 10,000 people to build our own office, but, maybe they have 500 people or 1,000 people and they say, "Okay, you can make use of the network." So, whichever office is closest to your home, something like that.
I see.
And so at the same time, you can go, any individual, you don't have to be employed by someone who's contracted with the group. They can go onto the website and sign up for $90 a month.
That's a steal compared with how much health insurance is today.
Yeah.
What kind of things are you seeing? Did you practice medicine any differently? It's two different models of kind of ownership, I would say, or health insurance side of things, but did you practice any differently or did you have more time available or describe that kind of breakdown as best you can?
Yeah. So, I'll preface it by saying I think most primary care physicians are generally good people stuck in a bad system. So, if your
Yeah.
doctor you feel like is making you come in too often, for example, it's because and it's maybe unnecessary. They just need to talk with you, right? Well, if the
Mhm.
doctor made a phone call instead of bringing you into the office would close because the way the reimbursement works, it just doesn't pay for those sorts of things, and so that you would cease to have your own doctor. So setting the stage like that, it changed my practice changed pretty instantly. All of a
Mm.
sudden, if I need to see you or speak to you for, let's say it's an anxiety follow up after we start a new medicine, or you go to therapy a couple of times, maybe I just bring you into the comfort of my office instead of an exam room, and I don't have the nurse take your blood pressure because
Right.
we really just need to talk in a comfortable setting. And then especially post COVID, like maybe we just text, "Hey, how's it going?" Because with the membership model, I'm not worried as the physician about billing out my visits every day. I'm worried about taking care of the people on my panel.
Mm.
And so that, maybe I'll have you come in every single day to check a blood pressure because that's what we need. Or
Mhm.
maybe, again, it's something we would have had to bring someone in for. We do by phone or video or text. So From that sense, it really changes the interactions between the patient and physician. And also, it really allows you to practice evidence-based medicine. So when you look at, folks with another thing about good docs being stuck in a bad system, you always hear, oh, they're, throwing pills at me, or, they're just prescribing me stuff.
Right.
Well, the first guideline for blood pressure, cholesterol, diabetes
Hmm.
is diet and
Lifestyle.
exercise, nutrition, lifestyle. Exactly. When I have 8 minutes to talk to you and make a change in your life, like, you're probably getting a script.
Yeah.
But if I have an hour, which we have in this model, we can sit
Hmm.
down and say, okay, let's talk diet. What's getting in your way? How do we set up a system? So I would go
Hmm.
through and calculate, what is your basal metabolic rate or your BMR? So if you were just
Hmm.
laying there, how many calories does your body need to function? And
Hmm.
then how active are you? And we'll estimate how many calories you should be taking in. We download an app while we're together to track that. And I can have my patients send it to me. I can review it for them
Super
just because
cool.
that's what you need. And so it drastically changes what you're capable of as a physician. And it also allows us to really practice what we want to practice, which is let's
Yeah.
talk diet and exercise and nutrition and help you sort through this without me throwing medicine at you or just a referral to a specialist.
Totally. I mean, it makes it more personal. I mean, what the 1950s primary care physician would be, sad to say, but I mean, you'd be walking hand in hand, like, hey, let me help you through this process rather than just, okay, yep, I have 39 other people to see in this day. Like, you got to hurry up and get out of here. Also, I got 39 other notes to, prep and get done.
Yeah, no, that's absolutely accurate. And just to touch on the community thing too, just to explain the logo in the background here, my wife is also a direct primary care doctor. So technically a
Cool.
competitor, separate office, separate program and all
No,
that
not with the
stuff.
same
But
one. No.
yeah, but we all in the community, there's a lot of us out there. We all bring each other up together. But, just looking around the office here, there's books that people have brought in. Sometimes they bring produce from their garden.
Yeah.
So when you say community, it really is a return to that community physician because you really get to know people. You spend time with them. They refer their friends and family. And so we do like
Yeah.
community events too, community walks, and people show up. And so, yeah, it's like return to the kind of 1950s doctor, but with modern day technology and medicine.
Right. Now touching on that, what kind of different technological advances are you seeing kind of in your practice? I mean, it could be the telehealth platform since COVID. It could be, are you guys having scribes or automatic, I don't know if use Epic or any other platforms, but like automatic DAX, scribing for your visits. Kind of touch on that. Give me your perspective on what things you guys are trying and seeing.
Sure. Yeah. So it's funny with the AI scribes, they've been a lifesaver for a lot of my colleagues, the ones especially who are seeing those 25, 30, 35 patients a day.
Right.
Talking to them and asking them about, I always try to hire them away, right? And they're like, yeah, well, I have my 8 or 9 hours of clinical care, and then I do dinner with the family or whatever, and go back on the laptop and flip on the TV, and I'm documenting for 2 or 3 hours. That's, it hits life quality and satisfaction. It's unpaid work time. And so technology is, the new one built into Epic, which we haven't got to experiment with yet, or I mean, you name your AI scribe, like they're making a big difference.
Right.
Now, if I'm seeing 5 or 6 or 7 patients a day, I almost prefer to write my own notes, and I'm not submitting them for reimbursement. So I don't need a perfectly, you know, a
Yeah.
curated note for the insurance company's AI to read and then reimburse me.
Right.
And so I can really just kind of plop in a few sentences that were pertinent. And if I want to, remembering my patient's dog is sick and to check on them next time, so my notes look a little bit different
Yeah.
than your traditional office note that a person can't read.
Yeah.
And so,
Yeah.
yeah, from that aspect, we haven't done a ton with it. I'm sure we will. Epic just announced their own agent, and we do use Epic in our organization. And
Gotcha.
so I'll experiment with that as we gain access probably in the coming months.
Yeah.
But yeah, technology wise is more, pushing the technology in our concierge branches. So we've instituted, it used to be stress test. Everyone would jump on a treadmill and do a stress test. We don't really do those anymore. We have DEXA scans in the office available to our
Oh, wow.
members. We have more advanced blood work, checking
Hmm.
things. Everyone's pretty familiar with like HDL, LDL cholesterol, but the
Hmm.
newer guidelines, not always paid for by insurance, include things like apolipoprotein B or lipoprotein A, uh,
Mm.
these cholesterol molecules that can really help us figure out your risk and how to treat you
Yeah.
more effectively.
Yep.
And so, yeah, technology is definitely coming in, and we phase in whatever we can as quickly as we can if it's going to move the needle for our members.
Sure.
But the non concierge, the direct primary care practice, is almost like the removal of technology is more helpful.
Yeah, because it makes it that much more personal. I mean, I'm sure some people are like, "Hey, I'm sick. I need to see you, but I don't want to come in." And you're like, "Sure, let's do a video visit for that one time." But when you don't have 40 people you need to fit in and, getting a telehealth visit doesn't seem that necessary. Is am I correct in kind of postulating about that?
Yeah, yeah, and not only are those not necessary, but it really does for the from the doctor's standpoint, it changes the amount of calls you get after hours.
Totally.
A lot of times just personally, be reaching out to a doctor on a, Sunday morning because I tried 3 times during the week to get my prescription refilled and I never got an answer from the office. Nobody acknowledged me. That sort of stuff doesn't happen in our model because the volume is lower and the barriers between patient and physician are erased for the most part. And so, yeah, I think a lot of those perceived like visits for XYZ may not be necessary. If I get a message that says, "Hey, I have that, pneumonia type feeling I get every year at this time. I'll go get an x-ray later. Can you please send in my medicine for me that I take?" Or "I'm having an asthma flare. And when you build that trust, it's the patient can say it's my usual asthma flare. I don't feel like I need to come in, but I need maybe a few days of prednisone, steroids to take. I would have no problem just sending in that script. But in order to get to that point where the patient doesn't require a visit, we build
Mhm.
a relationship, build trust. I've examined you, I've had hands on you multiple times when you've had these issues. And so we both know what's going on. And again, yeah, so you can avoid those unnecessary visits and also get back to that more old timey medicine. People know what they need when you listen to them.
Mhm.
Most of what we are trying to figure out on the physician end is from the history, is from the story that the
Totally.
patient tells us. And when you have that time and ability to listen, it really makes a big difference.
Yeah, I think I don't know if you were sold this picture. This is just a quick rabbit hole, but I was sold the picture going to PA school of physicians. They have no time left to see patients. So going to PA school, you're going to be able to spend an hour and a half with every patient. They get more time with you, and then you go into the work world, and you're like, oh, it's still the same guidelines. You're still, you need to see 1.3 patients per hour. You need to make sure your notes are all up to date, and you need to make sure you're practicing evidence based medicine, but also get him out the door quicker, and it's like we're being hit on all sides all at the same time. So I really enjoy what the things that you're describing make me
Hmm.
dream about what got us into it in the first place, you know?
Yeah, 100%. And the way you say that guideline too is like, does anything dehumanize a human interaction other than saying you need 1.3 visits per hour? Yeah, I mean, just sitting there calculating the numbers that you need is like, "Oh, yeah, I can't wait for that, third of a human to walk in so I can
Yep.
get this done." I
Yep.
mean, this is modern medicine, and
It
we're
is.
really trying to reinvent it in our model and stop doing that.
Well,
Yeah.
I think business kind of took over, and you can give insight into this from the business standpoint, but I think business kind of took over, or honestly is still actively trying to take over the medical world. And then there's these mini revolutions attempting to fight back against that
Mhm.
with the people who actually still, I mean, most medical providers still care to fight for their patients and actually fight for their care. But the medical world and all these MBAs are coming in and like getting their fingers into the depths of healthcare and saying,
Mhm.
you can make this more efficient. You can cut this here, cut that there, decrease the time off here, and then we'll turn this into an efficient business. And we're like, well, we don't need to be a business. We obviously need to make income, but it's not about the margins for us. It's about helping the people.
Yeah.
Does that ring true as well for you?
Yeah, it sure does. Nobody's getting rich in primary care. It's the lowest paid specialty, and that includes OBGYN, pediatrics, and
Yeah.
sometimes ER depending on the situation. But
Yeah.
these are really the front lines of medicine for all ages and all stages. And yeah, I mean, people aren't going into it. You're better off in other fields if you're trying to make $1 million a year or more,
Totally.
to
Totally.
sell your business to somebody. But yeah, there's this graph that's always circulating online about the number of administrators and number of caregivers
Yep.
in medicine. And, about 20, 25 years ago, you see them just kind of take off. And the administrator line hockey sticks, and the physicians mostly stay constant. And so there's definitely people who are not providing care, profiting off the system. And it's not just maybe like you said, MBAs in charge, which we still need people with business acumen
Totally.
in charge of hospitals and large groups. But it's all the hoops you have to jump through to get paid for, reimbursement on the insurance side, and the pharmacy world, which is a whole other beast.
Hmm.
Yeah, there's a lot of different hands and mouths that need to be fed from the system.
It's you remember? I'm sure you've heard of Dr. Glaucom Flecken,
But yeah,
the
enjoy his
YouTube.
stuff.
His stuff's so good just for the medical world because it's so accurate. But I remember one of his videos showing he goes in, oh hey, chief medical officer, thanks for you needed to see me, and it's one person. And
Hmm.
then the next week he's like, hey, I'm coming back just because I had wait, who are these three other people? Oh well, I had to hire them for this role and this role and this
Hmm.
role. And then goes back again the next week and there's four more. And you're like, what are these all? What are they doing? And they're like, oh well, they're technical officer assistant, second officer of technicality. It's like you get to a point you're like, are these just made up roles that they're
Hmm.
paying these people for? Granted, like you said, respect them because you need MBAs to run a business from a standpoint. But like you said, I mean, the hockey stick kind of mentality, and not just mentality, the graph, it shows, results show. And
Yeah.
I don't know. I don't know much about like how physician pay in those front lines. I'm emergency medicine, you're primary care, but you're
Hmm.
also trained probably in pediatrics as well and sports medicine. Like, I don't know if our front lines are increasing at all. I think we've hit kind of ceilings, whereas the specialties continue to increase because the reimbursements are so much better for the surgical subspecialties. Are
Hmm.
you familiar? This is kind of off topic, but are you familiar with that?
Absolutely. Yeah. Pay close attention. And I think it's most helpful because the finances of healthcare are so wonky. They don't,
Yeah.
supply and demand don't correlate. And there's so many opaque corners of this universe that if you look at like a traditional workforce, like finance, other industry, whatever, most standard, at least from what I've seen looking at other companies' P&Ls, is there's usually a 2 or 3% annual raise built in. Try to at least keep pace with cost of living or inflation or whatever consumer price index. I mean, you name it, they're usually tied to something that
Mm-hmm.
escalates for people. We don't have that in primary care, and there's sometimes cuts to Medicare or at least lack of raises.
Mm-hmm.
So, and Medicare is kind of the barometer for physician pay in our country. And so, looking at that, we've continued to take pay cuts for like the last 20 years. And, talking to my boomer generation, as we were talking about before, they're nearing or have retired. A lot of
Mm-hmm.
them who are physicians tell me their, best paying years just on raw numbers were 15, 20 years ago.
Mm-hmm.
And the dollar amounts have come down. And now think about that plus inflation. I mean, those are significant, significant cuts to, trying to afford your daily life, frankly.
Yeah.
Most physicians are very lucky and fortunate to be making the money that they are, but
Yeah.
anyone who, takes a relative pay cut every year for a good part of their career, I think has a right to be upset about that, especially when we see healthcare as such a kind of vital industry, and every other
Totally.
industry, you work in retail, you work in finance, there's annual raises happening. And yeah, you just don't see that in medicine.
And what used to be a generational kind of change for a family, like the Seidman family, two physicians, your grandchildren's grandchildren are set. And now we're getting into the days of I survived to have my children like survive. Not quite that bad. That might be a little too much or too fatalistic of a view, but yeah, it's now so transitioning based on that thought, tell me
Mhm.
about this new business opportunity or what you kind of stepped into this year, what role you're kind of fulfilling and how that relates in any way.
Sure. So as I continue to take a larger role in our organization, we would be pitching these on-site, near-site clinics to employers. So, hey, cost of healthcare is going up a lot. We have this great service that hits the sweet spot in terms of providing a great service for your people, and we can decrease your downstream healthcare costs because direct primary care handles so much early in a proactive nature. People go to the ER like 35% less, end up admitted to the hospital less. Their metrics are generally healthier, better control of blood pressure, better control of their diabetes, those sorts of things. So it really does amazing things. And that's why I'm so passionate about it and why I did it for so long.
Hmm.
But there would be a disconnect, right? So, like, as the DPC, we were in the room representing ourselves. The employer says that that all sounds great, like, and we have numbers to prove it over almost a decade now. And then there's the broker advisor who kind of is the transactionist, right? They like build and sell the healthcare to the employers. And again, I think it's a lot of good people stuck in a tough system, because if direct primary care comes in and saves the employer money, guess who else gets a big pay cut? Is the broker advisor to
Hmm.
the employer. So usually when we leave that room, there's another meeting. The most important meeting is the one we're not at. And all the stuff that we've promised and sold, they say, yeah, you probably don't need that. Let's just stick with what we're doing, and it'll go up a couple percent, but you're used to that. So the status quo is very hard to get out of.
Mm.
The employers, it's typically somebody in HR making the decisions for the plan, and a CHRO, for example. And there's not a lot of healthcare specific training. They do a million things at their company.
Totally.
Dealing with people problems, it's a hard job. I think one of the hardest jobs in an organization. And
Yeah.
especially as you take on more employees, like let's say you have a group with 1,000 employees, 2,000 employees, you're spending, upwards of $10 million a year on healthcare. And, to have somebody in charge of that spend who's also in charge of like 20 other things, I think it is a real challenge. And they just frankly can't dedicate the time to it. And so after seeing this repeatedly over the last couple of years, kind of got fed up, and I said, our model's great, it's growing, but I want to
Hmm.
make a bigger difference. And I think these employers could use a chief health plan officer. I think they could use a dedicated human for this large spend of money, whose expertise lies in employer relations, in healthcare specifically, and who knows the right levers to pull to save a bunch of money, but at the same time make benefits better.
Right.
So, and it's possible to do all those things. It's happening all over the country, lots of case studies. And so in January, I resigned from my medical director role. So I'm no longer overseeing the network of offices. And I'm pursuing this health plan design, chief health
Hmm.
plan officer, as my kind of next professional step. And
Cool.
yeah, I'm about 2/3 of the way through our first client project, which has been a lot of fun. I'm learning a lot. It's going well. We're going to drop some major knowledge, I think, on them at the end of the year in terms of insights and opportunities for improving the plan, and
Yeah.
yeah, continuing to put it out there and pitch in the community and show people that I think there's an empty seat at the C-suite table, and that
Yeah.
there's a good spot for this sort of role.
And so in this role right now, is it mostly data collection and analysis and kind of piloting for this one client, or so that you can have a case study to pull off of for future clients and kind of prospecting for that? Is that what I'm understanding?
That I think that'll be kind of like a happy side effect of this first client project, but yeah, that's essentially what we do. So, I first do a plan, like a free project scoping. So let's see how much you're spending, where are you spending it, and based on that, I can do some generalized projections of what sort of savings we could see. Very very basic, because it's we know that pharmacy spend with switching out some components of it, you could save 10 to 20%. So if I know your pharmacy spend, I can ballpark that savings based upon how aggressive the employer wants to be and how much they'll tolerate disruption to what they're currently doing, and innovation.
Yeah.
Because those are scary things when you're talking to an employee workforce about their benefits changing.
Yeah.
And so, yeah, we focus on data collection is a big one, because it's really tough to get data. That's still the hardest part of this. Compliance. So a lot has come through about transparency and being a true fiduciary of your health plan. So making sure that companies are aligned with all the new laws and acts that have been passed. And then finally, contract review. So there's a lot of that. We were talking about the opaque corners of the healthcare system. A lot of fuzzy contract language about how employers can be charged for things three, four, 5 times. And yeah, so it's kind of sorting all that out, shining a bright light on it, and presenting it to the employer and saying, if you can address these things, here's your potential savings, and you'll be doing some amazing things for your people. You can afford to give them great, great benefits. And so that's kind of like step one of the project. And then if they'd like me to implement that, stay on as a consultant, or really take on this health plan officer role, and then that'll be kind of step two for the clientele.
And do you anticipate being able to provide that service to multiple different businesses? I mean, to be that healthcare advisor in a sense at the C-suite level of you, like, do you anticipate sitting at that seat for multiple different companies? Or do you anticipate kind of having to kind of, delegate that task once you kind of uncover all the details?
Yeah, it's a great question. So, too early to tell. I
Okay.
think that
We're
I'm
still in the
right
baby
now
steps. Yeah.
still in the yeah, it's only been 9 months of work on it so far, but so I'm not saying no to any opportunity.
Sure. Sure.
Really trying to keep an open mind no matter the size and scale. My first client was actually way bigger than I was planning on taking on, which is a good problem to have. But
Yep.
it's like, okay, yeah, feet to the fire. Let's learn it quick. And yeah, it depends on the scale. So, I've talked to a lot of people in the industry over the last few years as I developed and launched this business. And even though the position doesn't exist in most companies, there are people doing this work. And the general consensus is that if there's a company with maybe 100,000 employees, that's a full time job
Yeah.
managing the health plan. But if you're looking at companies with a couple hundred, couple thousand, maybe even up to 20,000, there may not be enough daily work to make it a full-time position.
Okay.
And so, and you can also, learn from each other, right? Like, I think there's a lot of value in keeping the clientele a bit smaller and having a half dozen at a time, sharing
Right.
ideas, experiences, building better plans based on shared experience.
Good
And
point.
so, yeah, so I think at a certain size, it's a fractional role, and at a certain size, it's probably a full time role. I don't know which I will be doing if we talk again in a year or two, but
Yeah.
we'll see.
Yeah, let's see. I mean, we could talk in 2 years, and then you're like, "Hey, I'm actually sitting at 10 tables right now, and it's very part time for all of them, so I can actually balance it." Or it could be, "Hey, I have 2 spots, and I have to delegate a majority of my work because there's so much to do work off
Hmm.
of."
Right.
What has it? So it's been a pretty exciting journey. It sounds like this year so far. What are kind of so we've talked about the technical aspect of that, but what about business ownership? That side. I mean, eh, as a primary care provider, you're not trained in business ownership, but
Hmm.
you've had kind of I would say a soft transition going into the DPC model and probably being a medical director there. What things have trained you to see kind of the pros and cons of your business now?
Yeah, I like that question. So I was very grateful over the last 7 years with my organization, the founder and CEO, also a physician, didn't go get an MBA or something, just decided to open his practice and through brute force has, figured it out. They've been in business for 25 years. And so he was an amazing resource to just learn from and always he was always willing to share, here's what we did in the past and here's how we got to this point if something didn't make sense to me. And so, seeing an example every day of somebody doing it I think
Right.
gave me confidence. I do think physicians undersell their ability to start a business
Hmm.
and manage a business because we're so kind of swept into our education, as I'm sure you had to do, right? Like undergraduate, there's graduate school, there's postgrad training. You spend 10 years obsessing over medicine and you don't have time for much else, but you forget that you were like a capable human before that and you have a brain and you can use it for other things besides medicine.
Hmm.
And so kind of seeing that as an example, also my wife being the entrepreneur that she is, knowing that there's an expert in house, literally in house that can help me out if needed. But,
There you go.
it's amazing. It's in our country, like it's pretty easy and pretty inexpensive to start a business.
Right.
Insurance for it is another thing, but so that journey's been great. I love managing people, but I have a couple young kids, and I just was, empathy was on zero for a while, and
Right.
so not managing people in my own business has been a nice break.
Right.
Even though I did love that work, and also having your time to yourself. It's kind of a double-edged sword because being accountable to people is very helpful when you're trying to be productive
Totally.
and I, don't have that right now because I'm not working with a team, a dedicated everyday team like I was
Yeah.
before.
Yeah.
But at the same time, your time is your own. So I've been able to restructure my day to send both kids off to school. I take piano lessons, something I've wanted to do my whole life.
Very cool.
Yeah. So until I get busier, I'm structuring my time the way I want it to and still getting my work done and working hard on it. So
Yeah.
it's been fun.
Yeah, and you can be very kind of I'm glad to hear that you're having that you're filling your cup in a sense. You're filling the cup because it's been poured out onto, all the patients and all the time that you've kind of served patients so far. Now you
Hmm.
have this season where you're like, "Okay, I can get all my work done in 2 hours," or this day, maybe I'll need a little bit more time, but
Hmm.
no one's on the back end saying, "Hey, Dr. Seidman, you got to spend more time doing this or see more patients in this period of time." You're like, "No, I have the freedom to make my own schedule. I have the freedom to start myself." And so, what are some other pros and cons of like the business itself? I mean, have you been trained in the financial aspect? Have you had to kind of, feet to the fire, learn that kind of thing? What are other things that you're kind of recognizing so far?
Yeah, so I think all that stuff was way scarier until you get into it. It
Yeah.
sounds like it
Yeah.
sounds overwhelming when you're seeing patients and making decisions and overseeing people to like, put out a budget or manage your own P&L. But, thankfully software is an amazing thing and like QuickBooks has made it really easy
Yep.
to manage all that stuff. And AI has made it super easy. You still have to, we're still in the age where you have to double check and verify everything. But if I have a complicated question, throw it in there and just look everything up afterwards to make sure it makes sense to me. And there's also a lot of people who are willing to share their expertise, especially in the direct primary care community. So there's a lot, most DPC offices aren't an 8 office network like ours.
Sure. I would
Most
say
are
they're 2 to 3
individuals,
ish at
two to
most.
three, yeah, or one
Yeah.
or one. So there's a ton of, now thousands of physicians who have gone out on their own, and many local and nationally are just willing to say, hey, here's what I did. People post to our private Facebook group and other private communities about like, hey, how did you get through this problem? Or, here's my finances right now. Can someone take a look and tell me what they did differently? And oh, you're spending too much on rent. You should consider another spot. Just getting expert opinions from people who have been through it. It's a very supportive community. I've learned a lot from that, but also I'm a learn by doing guy. So you just try not to screw it up and make sure you're using reputable resources. But so far, so
Yeah.
good.
Yeah. Or at least
Yeah.
not screwed up too bad because we do like to learn
Right.
from our experiences.
Yes. Yes. Don't get audited. Don't commit fraud.
Yeah.
Do
Those
do the right
things.
thing. Do the right thing. If you end up with a little extra waste because of XYZ or you didn't, tax plan efficiently, like these are all things we can learn from.
Those
So
are
yeah, it's
yeah,
been
those are the
good.
great stories 5, 10 years down the road to
Yeah.
say,
Right.
"This is what I was doing early. This is the mistake I was making. I bled a little bit too much money in the first 2 years." But in the grand scheme of things, it's like, I got to learn from it. I have an
Right.
opportunity to learn from it.
Absolutely. Yeah. I think that's the way.
What, you kinda touched on, using AI as a helper. What kinda things do you see we can use this with the DPC model as well. What medical applications do you see for AI there? But also, what do you see in your business going forward from this
Mhm.
point on?
Yeah, so I think AI is great. In direct primary care, we're going to see, especially as it comes into our EMR, how it affects, day to day operations.
Yeah.
My overarching hope is that we use it to automate the tech stuff to increase the amount of human interaction. I think, so much of the conversation is, well, it's replacing jobs, replacing humans, whatever. I think the best place for technology to be is just like operating quietly in the background.
Mhm.
If I could just bring a patient into my office and we could sit down and talk and I don't have to have a computer in between us or they don't have to check in on their phone and use 25 steps to sign the same document every time. Like these are the things AI I think would be very helpful for in the office. Like
Yeah.
you should be able to walk in, have it recognize your face, automatically bring up your stuff, tell you to walk into the office. It'll document your conversation. So you just make sure you say the right things and talk about the right things with your patient, and they can walk out and get their after visit summary emailed to them automatically. This is where I would love to see AI
Yeah.
have a role. And unfortunately, in medicine right now, it's just like billing and coding.
Right.
So,
Right.
the recent article I read is, the AI note takers have gotten so good to get the proper billing. Now the insurance companies are using their AI to fight back and lower like the codes for the visits.
No.
And you have to, yeah, you have to make a phone call to, override that. And so, this is not the ideal situation or the
No.
use case for AI, in my opinion, but this is what's happening right now.
Yeah.
Yeah, and so but separately in my new business, I think, items like contract review as I feed it, and
Yeah.
I've had to invest in private and secure AI, which again, that's just
Yeah.
kind of cost of doing business these days.
Yep.
But you feed it contract information, you teach it how to be a contract lawyer, and then
Mhm.
it will find those little, oh, actually for prescriptions, this company is getting paid 3 times, and here's the lines in the contract that state how, and here's the ambiguity in it. And so it'll be like a force multiplier for me for reading, reviewing legal documentation,
Yeah.
checking for compliance, because it can search national databases of, is the tax filing for this company being done properly every year and on time. So there's a lot it can do, but again, I think it removes the technical things and allows you to be the human in the room with the other humans to really talk about helping people and putting systems in place that allow folks to get easier access to better care.
Yeah, and that's the hope. That's the hope that it trends towards that. I
Hmm.
think some people have, and it's all about what you use it for and what you train it on. Like, what can it learn from the different things? Like you're talking about, it can learn how to be a contract lawyer, but sometimes you just need a lawyer just to oversee like that side of things.
Hmm.
But can it do all of the heavy lifting up front to be able to have a lawyer come in on the back end and say, "Yep, looks good,"
Yeah, exactly.
saves a
Exactly.
lot of time, saves a lot of expenses, we hope. And
Hmm.
especially on the optimization side of like clinics, I think, again, healthcare for some reason, it just always lags. It lags in any kind of forward thinking motions is what I see it. When it came to healthcare systems, I used to work in a big healthcare system in New Mexico, and the adoption of just the optimization of our EHR. I was like, guys, I should be able to, we have 5 different locations for an emergency room. I should be able to log in and see if my patient, I'm notified that the one I saw yesterday at this location went to this other location. Why can't I see that? Why can't I
Right.
see that they bounce back for some reason? Why can't I see any of this? This is not ideal. And it's just little things like that that other businesses figured out 15 years ago, 10 years ago, 20 years ago. And we're coming to the point where we're like, okay, these things need to get going a little bit sooner,
Yeah,
you know?
absolutely.
Um, we've had a great conversation so far. Any kind of closing thoughts or, you can talk about your business, any closing thoughts about, the DPC model that you want our listeners to know about, or where they can find you or where they can find other DPCs in their area since we're kind of nationwide at this point.
Hmm.
Yeah, just would love to hear your thoughts.
Absolutely. So, yeah, easiest place, and I'm most active on LinkedIn. You can see my websites, the work I've done, clinics I've run, all that stuff is easily available. So you can find me under Danny Seidman. And yeah, I think in terms of your other comment, I like to put it out there that healthcare is not doesn't have to be the dead end that people think it is in terms of work. There's so much negative news and energy that comes out about primary care and practicing medicine.
Right.
And, there's studies that say, parents are telling their kids not to go into medicine and all these things. And,
Yeah.
but there are so many different paths you can take. And it seems like really scary, to do what I'm doing. Talk to, people 10 years ago, my colleagues are looking at me like I've got a third eyeball on my forehead. Like, you're crazy. I can't believe you would do XYZ. This is the way we do things. But
Right.
I've just seen that leads to suffering and early retirement for my colleagues. And, you can go to medical school or PA school and get your degree and get your training and go do amazing things and help people. You just have to work hard and, be creative about what you're doing and also prepare yourself for every opportunity so that when it comes up, you're able to jump. Nobody has ever been Yeah, most people, in my experience, is that I've never been upset about jumping at an opportunity, even if it doesn't work out. You kind of always, regret the ones that you don't go after. And so
Right.
being ready to say yes, to say, I can do that, or I'll figure it out,
Yeah.
or to, go to that meeting, go to that dinner, go to that networking event, whatever it is, like you can go do those things. And it just expands your ability to not only help people at scale, but also have a long, satisfying career in medicine. So that's my message to residents when I go talk to residents is just you can do academia, you can do this stuff if it makes you happy and you're helping people, great. But if not, there are other paths. So don't
Yeah.
give up.
Don't give up. Don't give up. You can tell that you've talked to a lot of residents.
It's passion, it's a passion of mine. I feel like now that I got out of that system and I've like nothing horrible happened to me, I still have a house, I still work, I
Yeah.
can still help people. Like I feel like it's my duty to make sure doctors in training know there's another way. And so, yeah,
Yeah.
I as many times as I can per year, I get into residencies to kind of spread the message.
Oh, I'm glad. I'm glad.
Yeah.
We need the special ones like you who aren't the burnout, the burnout. Don't go into this, kind of mentalities or viewpoints. So I really appreciate your viewpoint. That's very refreshing, I think, for my community as well. You know,
Awesome.
but yeah, thanks for your time. Really enjoyed getting to talk to you, getting to hear your perspective. Really excited to see what comes, not just from
Thank you.
your past experience, but also to see what comes from this new venture. New ventures are scary, but it's kind of uncharted territory. So look forward to checking in 2 years, maybe. We'll see where things are at.
Awesome. Yeah, and likewise, Ben. Great to meet you here face to face, and thank you for your time and for having me on today. And good luck to you as well. Be fun to
Yeah,
follow each other along.
appreciate it. All right,
Yep.
have a good one.
You too.